Rick, just a huge thank you to you, Rick. You've become quite the friend of our foundation and our educational platform, and our fellows benefit so much. I think last year you were voted the best talk of the year, and
Oh, come on.
it's great to have you. Rick is all things cervical, and what I love so much about his talks is so practical. I always walk away a better surgeon, and so thanks for being here, sharing with us, taking time out of your practice, and being a part of our family here. So appreciate you, Rick.
Thank you. Well, I appreciate doing
Thank you,
this. This
Ted.
is really fun. I've really enjoyed doing this, and congratulations on putting this on. This is just a terrific forum, and I've learned a lot by you know, Monday morning coming on and listening to some talks and getting really smart about different things. So thank you. Thanks for doing this, you guys. So can you see my
Yep,
slide?
we can see it.
Yeah, perfect.
Is it in presenter mode or is it okay?
It is.
Okay, great. So, this has been a long journey for me. 22 years ago, last month, I implanted the first cervical disc replacement in this country and been involved in almost every IDE trial, FDA IDE trial, including 3 that we're doing right now, and the last 2 FDA approved discs. I was the highest enroller in the Simplify and the highest enroller in the M6. So I've got a lot of experience in cervical arthroplasty. I'd like to share with you some of my thoughts that I've developed over the last couple decades doing this, and also talk about some tips and pearls for just general cervical arthroplasty, not specific for one implant, but what I've learned using a bunch of these over the years. And I'd like to start this with a case that maybe will help uh, solidify sort of some of my thoughts. This is a lady I saw 22 years ago. She had a 6-week history of left arm pain, very typical for a C7 radiculopathy, unilateral. And she had some, as you can see here, some arthritic changes at 5'6". 6'7" looked pretty good, but her symptoms were typical of a left C7 radiculopathy. And as you see on this MRI scan, I can tell you that in a lot of places, a lot of surgeons, they would not think twice about this. This would be a 2-level ACDF. And we had just started the IDE trial for arthroplasty. And with this MRI scan showing this sort of acute, what appeared to be an acute left-sided disc herniation. And I thought this was an acute disc herniation. This was old. And we did a selective nerve sleeve injection that made all of her pain go away for a short time. And that was positive. And so what I did was a single level arthroplasty. This was in October of 2002, and she did great. Her NDI was 0, VAS of the neck was 0, VS of the arm was 0. She overall had a fabulous outcome, and obviously still had this degenerative 5'6" disc. I saw her 18 years later for a lumbar problem, and while we were getting the MRI of the lumbar spine, I remembered her very, very distinctly. I said, let's get an MRI of her cervical spine. And again, you see this degenerative 5'6" disc, but I would argue that actually MRI even looked better 18 years later at this 5'6" level. And again, she was completely asymptomatic in regards to her cervical spine. We looked up all of our patients, as many as we could, at 20 years. And so 2 years later, at her 20-year follow-up, here she is. And again, she's completely asymptomatic in regards to her cervical spine. We did her flexion extension and side bending x-rays. And I'd like to, again, share with you just a bit. We just published this last few months ago. the 20-year outcome, and what I'm super proud of is that we had a follow-up rate of over 90%, which is really hard to do, as all of you know. What's interesting about Indiana, we're kind of like Iowa. Patients, people don't move a lot from it. It's not like Southern California where a lot of people are coming and going. So we have a pretty stable population. So we had a really high follow-up rate. And what you'll see here is that at 20 years, both arthroplasty and fusion did really well. Although the numbers are a little bit better for the arthroplasty, this is not statistically different. And even if it was, it's not clinically different. It's much less than 15-point range of the NDI, which is a clinically significant difference. And also, likewise, VAS of the arm, this is not statistically different and not clinically different either. And VAS and neck, same thing. Very good in both groups at 20 years, but not statistically different or clinically different at 20 years. And so I think as cervical spine surgeons, we can be really proud of what we do with ACDF and arthroplasty for cervical radiculopathy. Statistically significant changes all the way out to 20 years without significant statistical difference between the two groups. Looking at reoperations, though, and we were, even those that didn't all follow up at 20 years, we had some data, some reoperation history. And so overall, more than 95% of our patients were able to have some reoperation history. And this is what is really interesting to me, because at 10 years, there was not a statistical difference between the two groups at 10 years, but at 20 years, there was. And what was really interesting to me, at the target level, no reoperations in the arthroplasty group. We had one reoperation in the ACDF group, and that was a symptomatic pseudoarthrosis that was fixed with a simple posterior cervical fusion. Adjacent levels, we had 5% adjacent level reoperation in the arthroplasty group, 30% in the fusion group, and non-adjacent levels. And this is something we don't talk a lot about. I spend a little bit of time on. So not target level, not adjacent level, but a remote level. We had 5% in the arthroplasty group and just over 15%. So when you look at any reoperation, statistical differences favoring the arthroplasty over fusion. And again, this is different than what we found at 10 years. So overall, reoperation rate, statistically significant differences at 20 years. And I think what we don't spend a lot of time on is, I'm sorry, but this is not coming across here. But anyway, what about non-adjacent levels, and what does that mean? And I think that what is really interesting for me is looking at if you look at survival constructs of arthroplasty. I mean, the hip and knee surgeons would love to see a survival construct 100% at 20 years. And even if you look at ACDFs, really overall, really high success rates. And when we look at this 10% 20-year reoperation rate in arthroplasty, is that really sort of think about the upper bound? We don't really know what the natural history is. Someone who obviously has had an operation for radiculopathy or mild myelopathy, they are going to have a higher incidence of other level problems. And what is that incidence? And maybe that's what this is. Maybe it's 10%. So I'd like to also talk about, we looked at radiographically very closely at 20 years and found that looking at the total range of motion at 20 years, there was statistical differences favoring more motion in the arthroplasty compared to the fusion. And obviously, at the index level, statistical differences. And what's really interesting, obviously, essentially no motion in the arthroplasty group told us that our operation worked. We had no motion at the fusion level. But looking at range of motion, everyone asked this, what if it was any decrement over 20 years? Look at this. Immediately after the operation, range of motion, flexion extension 9.7 degrees, and at 20 years, 10.2 degrees. No difference between these. So the range of motion continued to be normal at 20 years. And looking at adjacent levels, at the adjacent levels, both cephalad and caudal adjacent levels, both groups had narrowed disc over 20 years, but did not narrow as much in the arthroplasty group. Statistical differences, both cephalad and caudad. And looking at adjacent level degeneration measured on Kellgren-Lawrence scale, again, there was statistically significant differences favoring the arthroplasty over the fusion. Now, as we talked about, these are all one level operations, but I think that even more compelling is the data of two levels. So some patients I think do need, and this patient had a left C5 and C6 radiculopathy that needed an operation. And clearly, if we can do an arthroplasty as opposed to a two-level ACF, I think that is a much better operation, even better than the one-level data. When we look at a meta-analysis of two-level data, arthroplasty over fusion, the results are very, very compelling. I'd like to review sort of some of the things that I've learned over the last 20 years overall about artificial discs. And number one is to be very careful at the C6-7 level in big-chested men, especially. This patient is in the operating room, is intubated, and the plan was to do an arthroplasty at C6-7, but you can hardly even see the C5-6 level. The difference in doing an arthroplasty as opposed to fusion, it's my opinion, you absolutely have to see the posterior aspect of the vertebral body, the posterior aspect of the disc to safely put in an arthroplasty. We don't need to do that for an ACDF. We just have to be able to count and be able to make sure we're at the appropriate level. So be very careful in these big guys, big-chested guys, if you can't see the C6-7 level, and tell patients that may be an issue for them. Avoid arthroplasty and deformities, whether it's in the apex of the deformity or even if it's away from the apex of the deformity. This, I will tell you from personal experience, you will be sad looking at this arthroplasty for the rest of your career. This is not a good candidate for an arthroplasty. Also, in what I call bone formers and patients who lay down a lot of bone, and as you'll see here, this was it was in the FDA trial, the Bagheera disc. I thought I avoided this big, huge anterior osteophyte here. I thought, well, maybe we'll be able to get away but these patients are genetically predisposed to lay down bone, and you see what happened within a year. This patient actually developed a myelopathy from this posterior osteophyte that occurred here. So again, some patients that are genetically driven to lay down bone, if you allow motion to occur, that can be a problem. And if you think this is bad, at least we can see this in those patients that have a cobalt chrome disc if you think that that patient, you may be concerned about myelopathy down the road, look at this. This is really difficult. This is insurmountable. These patients, you're going to have to get CT myelograms, and then we actually even a CT myelogram can't assess for intrinsic cord change. So be very careful using cobalt chrome discs if you think that you may need to assess the spinal cord. Also, after multi-level fusions, be very careful. I think next to a single-level fusion, an arthroplasty is a reasonable option, but next to a multi-level fusion, I think there are a lot of stresses, more stresses than most of our arthroplasties can take. And be very, very careful about at the end of a long segment fusion. But I'd like to talk about some tips and pearls about how I look at and how I do an arthroplasty different than I do an ACDF. Looking at some simple things such as positioning patients, how I define midline. Doing an ACDF, we don't have to be perfect in midline, but we do with an arthroplasty. And I'll tell you how I define it. And just as a spoiler here, it's not with X-ray, but we'll talk about that. How important it is to place our pins parallel to the disc space, which is not that important doing in ACDF. How complete neural decompression is super important, especially on the asymptomatic side, and how resecting the PLL, in my opinion, is really important. We'll talk about that. NSAIDs for heterotopic ossification prevention, and just a bit about end plate preparation. So how I position a patient for an arthroplasty is different than how I do it for an ACDF. For an ACDF, I put a roll under the shoulders, let the head tip back, get a large corridor for our exposure. However, I don't do that for an arthroplasty. Actually, the roll goes under the neck. You want to have the head, the back of the head, and the shoulders on the same plane. And the reason is if you hyperextend the cervical spine, you have a tendency to take too much posterior end plate away. And depending upon what arthroplasty you use, actually that may cause the shells to go into a relative kyphotic position. So that's one of the biggest causes of shell kyphosis, is taking too much end plate posteriorly, and that's because of the patient being in a hyperextended position. So I place a towel or the roll under the shoulders as opposed to or under the neck as opposed to under the shoulders. Now, the difference that this can cause, the reason we put it on the shoulders for an ACDF is to open up this corridor for exposure. If we don't hyperextend, our corridor may be a little bit narrower, and we just need to understand that the chin may be a little bit more in our way if we don't hyperextend the patients. And we just need to understand that when we do an arthroplasty. How I define the midline. The midline is super important to define. I will tell you that X-ray is probably one of the worst ways to define midline if you're looking at spinous processes, because spinous processes can fool you, and also a little bit of asymmetry in the X-ray can fool you. I've been fooled in every way possible trying to define midline with an AP X-ray. How I do it is I do not use a bovie until I get on the front of the vertebral bodies when I'm doing an arthroplasty. And because most of these patients don't have a lot of degenerative changes, there's not a lot of osteophytes when we do arthroplasties, I define the midline best by longus colli. I'm looking at the longus colli, and just like kicking a field goal between the goalposts, looking at the longus colli and taking that point right in the midline and taking my bovie and from the target level up to the disc above and the disc below, making a line with my bovie, and that's where my Caspar distractor pin is going to go. And the only time I actually get an AP X-ray is at the end of the operation after the arthroplasty is in. And again, I don't look at the spinous processes. What I'm looking at is the uncovertebral joints. So looking at the uncovertebral joints and making sure that my implant is centered between the uncovertebral joints. That's what I look at on an AP X-ray, and not necessarily the spinous processes. All right, so sorry about that. All right, so then place the distractor pin along where I make that, and we want to make sure that the pin is parallel to the disc space. And the best way to do that is to look at the cephalad end plate of the caudal vertebra. That is the best approximation for the angle of the disc space. So I place the first pin in the caudal vertebral body parallel to that end plate, and then place the cephalad pin parallel to the caudal pin, and that should place these pins exactly parallel to the disc space. Again, once your pins are in, everything becomes pretty simple. Now, most of these systems have a way of locking the distractor onto the pins. I tell you, that's a bad idea. Now, the concept is to keep the distractor from walking up on the pins. But what happens is now you put the stresses on the pins, and so now you have a tendency to cut the pins out through the vertebral body, especially if you're going to do a 2-level. This intervening pin is at risk. It's at high risk of plowing through. And so you want to be nice to these pins. And so whereas most of the time with doing an ACDF, I just distract off my pins. Doing an arthroplasty, I don't. I use intradiscal distractors to get my distraction and then just hold them with the pins. Get the distraction with the intradiscal distraction and just hold it with the pins. It's super important to take the PLL not only on the symptomatic side, but on the asymptomatic side. One of the biggest sort of reasons for revision operation is contralateral radiculopathy, because you did not decompress the side of that was asymptomatic and allowing motion to occur. This can be an issue. I don't know why this video is not running. Sorry about that, but that just is showing resecting the PLL and how important it is to resect the PLL. Obviously, in patients that have a fusion, I don't place them on non-steroidals, but every patient that gets an arthroplasty gets 2 weeks of non-steroidal anti-inflammatory medicine to hopefully prevent heterotopic ossification, and that has been shown to be a successful way of decreasing HO, although it's not 100%. Just one word on end plate preparation. Super important to have a foundation to place our arthroplasty. And what's important to know is that this cephalad end plate of the caudal vertebra is not flat. Because of the uncovertebral joints, it's like a football. It's half of an ellipse. And sometimes there are osteophytes here that cause significant asymmetry of this foundation. And what you don't want to do is have something like this happens. And you know why this happened, because they decompressed this side over here, ignored this side over here, because this was the symptomatic side. And an arthroplasty like this, and a MOBC just goes to where the path of least resistance, and that's what happened here. And to avoid this, what I do is I use a barrel burr. This burr is a smoother rather than a cutter. It actually it rotates opposite the way that it's cutting, so it smooths the end plate. So what I do is smooth the end plate, and this is a video. I don't know why it's not, but anyway, place it in the midline and just go laterally to smooth the medial aspect of the uncovertebral joint to allow a solid foundation. In my opinion, what is most favorable for an arthroplasty is single level. We told, as I said, if you have to do a 2-level ACDF, I think 2-level arthroplasty is best. But if you can limit it to a single level arthroplasty, that's better than a 2-level arthroplasty. Focal disc herniation for radiculopathy, unilateral in a young patient with normal facet joints and no significant degenerative changes. That, I think, if you keep your indications to that, you will be a very happy cervical arthroplasty surgeon throughout your career. Thank you so much for your time and attention. Happy to answer any questions that you guys may have. Thank you.
Yeah. It was awesome, Rick. Thank you.
Thank you.
This is David.
Thanks, Dr. Sasso.
Hi, this is David, one of this fine fellows. I guess in terms of stretching the indications for no significant degenerative changes, do you have a hard cutoff for like disc height loss, or what are the sort of gray areas for you that you'll try it on?
Yeah. So as you well know, and you guys being in Southern California, you guys see it all. Boy, I tell you, when I give this talk to some of the Southern Californians, boy, they want to lynch me, saying, of course, we can do all sorts of degenerative pathology, even those patients that have a fusion. We can reverse fusions. Fusion is a horrible, horrible thing to, I guess, a lot of Southern California patients. So reversing fusions and putting in arthroplasty may be an indication. I think that that's a little crazy. But I will tell you that unfortunately, I've seen way too many patients where the indications have been stretched and patients continue to have symptoms mainly from facet-based pain. And so, in my opinion, significant facet changes are still a contraindication to me. What in the old days, anything more than 50% disc height loss was a contraindication, but I have been a little bit more liberal in that. Patients can have a little bit more disc collapse as long as their facets are okay, at least in my opinion.
And are you
So I
assessing
have
that with
stretched the indications a
scans
bit.
or
Pardon me?
your facet? How are you evaluating the facet joints?
Great question. Just X-rays. I'll tell you that the original FDA IDE trial, the Bryan disc, we got CT scans preoperatively on every patient to not only measure the disc space for the implant, but also to look at the facets. And I will tell you, my impression is good lateral X-rays are just as good as a CT scan in assessing significant facet changes. So I do it just on the lateral X-ray.
Can you speak a little bit about your typical revisions if needed? Are you addressing this via like the inner body or that patient with concern for myelopathy? Or are you just doing a posterior approach and leaving the arthroplasty alone?
Great question. So if I can leave the arthroplasty and just do a posterior fusion, posterior decompression fusion, I will do that. Unfortunately, some patients do need to have the arthroplasty revised. I'll tell you, the last revision I did was in a patient who had a complication that I'd never seen before. It was a patient that was done elsewhere. He had a Moby disc put in, and the surgeon did a very good job, but the patient developed hives. And when I'm talking about hives, I'm telling you, they were like welts throughout his upper torso and face. And he was allergic to cobalt and chrome. Went to an allergist and said, yep, you are allergic to that disc. And I'd never seen that complication before. So I had to actually take it out and revise it to a fusion. But I'll tell you, removing, especially things like a Moby C, are very easy to remove. It was not complicated to do. But if you can avoid removing an arthroplasty, especially something with a keel, that would be optimal.
Hey, Rick,
Hey,
can
go ahead,
you
Steve.
hear me?
Yep.
Yeah, we can hear you.
Okay. Hey, so I'm Steven. I'm one of the first year attendings here. So in fellowship, we didn't use Caspar pins for disc replacement. We did Gardner-Wells tongs. What's your thought on, the thought was that you could put the Caspar pins in, and they're asymmetric or they're twisted to one side, and you're going to asymmetrically kind of distract the disc space. I mean, what's your thoughts on that? And being new to this, I feel like it's really easy to do
I'm
that.
going to tell you, Gardner-Wells tongs, I trained in my fellowship. We did not use pins. We had the anesthesiologist pulling on Gardner-Wells tongs. That is a very unprecise way of distracting the disc space. I'll tell you that. Also, I like pins because once my pins are, basically, no matter what arthroplasty you're using, most of it is dependent upon making sure that you get parallel distraction. And once you get that first pin in, as I said, the caudal pin that's parallel to the cephalad end plate of the caudal vertebra, and place the cephalad pin parallel to that, you are guaranteed of having parallel distraction, and you can actually dial that in very, very well. Now, the important thing also is make sure that your pins are far away from the target disc. Many times people put the pins too close to the disc, and depending upon what disc replacement you're using, sometimes depending upon how the end plates are prepared, you may box yourself in by having your pins too close together. But I do not like Gardner-Wells tongs distraction, and I think a much more precise way is using Caspar distractor pins.
Rick, I've got a little bit of a loaded question on the data that we have. As we tout, it's some of the best data we have, the IDE trials. On the other hand, it's cherry picked, right? The indications restrict. The use in the real world is much more broadened in terms of indications. And what's your sense of the real number? I mean, we know what the IDE trial numbers were in terms of the 20-year outcomes or 10-year outcomes, but when the rubber meets the road in the real world application, where do you really feel like disc arthroplasty is performing on, index level revisions and reoperations in general? You think it's
That
as
is a
low
great
as
question. And I talk about this all the time because you are absolutely right. These are super selected patients. And the operation is done by what I call hyper technical surgeons. For you to be, and especially in the early arthroplasty trials, you had to be really involved in this. And so you had super selected patients with hyper technical surgeons. And so you're right. Maybe the outcomes are not what we're going to see in patients that aren't super selected and surgeons that may not be so involved in this technology. And unfortunately, we see not as great results in the real world. And I think it has a lot to do with expanding indications, and not really so much a technique can't be that good if it can only be done by hyper technical surgeons, right? I mean, ACDF is a great operation. That's why it's still my favorite operation. That can be done by the regular run-of-the-mill spine surgeon, and he can have a great outcome with an ACDF. And I think arthroplasty should get to that point as well. But I think one of the reasons we're not seeing as great of outcomes is because of the expanded indications. The problem is, as we already talked about, how far can we expand the indications? I think that we're a little too strict in the disc height loss issue, and I allow even more than 50% disc height loss. But again, in my opinion, if you have any significant facet arthropathy, those patients don't do so well. They continue to have neck pain. You may make their ridiculous symptoms go away, but they still have axial pain.
I agree with you. And by the way, all those Californians are in Hollywood, not down here.
Yeah. Hey, we're the Midwest of Southern California.
I love that. I'm going to
Well, they-
describe San Diego that way from here on in. The Midwest of California. I love it.
Once you get this far southwest, you don't go anywhere else. Like patients stay here too. Like there's no further south to go, right?
I love it.
Hey, Rick,
Tijuana,
you
baby.
guys-
Well, thanks, Rick, for an awesome morning. Appreciate you.
Thank you. And thanks for
Awesome
all you
pearls
do.
insight. All right.
Thank
Have a
you.
great day.
We'll see you next week, Rick.
I can't wait.
Thank
Everyone else
you.
just log into the other meetings.
Thank you.